Good afternoon. The funny thing, probably the way to start this is session 1 of the course. It also should be fun, but this is session 1 of the course. However many of you are actually taking this for credit, I'm glad you are. We will periodically ask you throughout the next several weeks what we're doing well, what we're doing poorly. What I did get when I did this session alone last year, and one of the members of our executive committee said, that was really great, but you can't do it alone anymore. You'd have much more fun if other people were on the panel, as in you shouldn't do it at all. So I said, well, why don't we split the difference and I'll do some of it. Please do this. Ryan Hollywell is really, without him, we do nothing. And so he really has been tremendously helpful. He figured out how to do this. And what this is, please enter the POLLEV into your web browser. Do not, as I did to begin with, search for it. It won't work. Just enter it into your Chrome browser, your whatever browser. There will be a question that comes up. Okay? That question looks like this. Now, as Ken wanted to know, it's who will or who do you want to? These are two a little bit different questions. So I suspect this is about who will. Now, we're gonna sort of.
I voted with my heart and not with my brain.
Absolutely. Now, one thing is really important. As I said a few minutes ago, unlike most of these, you cannot change. You can change your mind all you want, but you can only hit that thing once, and that's it. So you're stuck with it, which is why, as Anita said, the drinking starts after this rather than before. Yes, in the back.
Unfortunately.
Sorry?
Back up the slide so I can put the website in my browser.
Oh, absolutely. Sorry. That was only if I liked your answer, though. This is on all the other slides, though, right? As we go forward, this website is on each of the other slides. We just didn't have it on the second slide. Okay, so here's how this works. Boom. And boom. I hope. Good start.
Did you click it twice?
Click it twice. Click it. Ah, there we go. Like I said, now we got to have a sense of humor here. This is the first time we're doing this.
Okay.
Wow. Okay, so here's how this is going to work for the next little while. We will vote, and then obviously we will vote on healthcare issues. And then I'm going to ask the panel to discuss a little bit as they would like, and the audience. And so if you have a particular point of view you'd like to share with us, because you don't have to specifically say, well, how many of us said yes to the Patriots? Looks like almost. Well, Anita, you're happy, right? Because you said basically everybody should be for the Saints.
That's right.
Okay. Got it.
I even tried to prompt them, but not everybody would pay attention.
Okay, here we go. So, and then now this doesn't really work. So this is, okay. Now, this is a real one. Pause and wait for results to load. Don't click twice. Keep your mouth shut. Well, all right. Okay, this is real now. The U.S. has the best healthcare system in the world. True. A. False. B. You get to answer once. And you probably have a thought about that, so let's see how. All right. So here we go. 19% whole true. Now, would anybody in the audience, we can, because I suspect, I don't know, we'll see what the panel has to say. Would anybody in the audience like to speak to true? Anybody like to, because obviously I don't know who you are, but terrific. Yes, sir. What was it about this that felt true to you?
Well, the unfortunate thing is...
Maybe stand up, would that work? Okay, here comes a mic. Or not. You only get the mic if you answer it the way we want. Okay, here comes the mic.
Thank you very much. The real question is, what is the question? What is the metric for best? And I think if we define best in terms of the quality and volume of innovation that is available to us, in terms of the progress that we have, medical technology, the new techniques we're developing, then the U.S. does have the best healthcare system. If you look at numbers like how many people are served per capita and the affordability, there's a lot to be improved upon. But when it comes to the potential and the innovation, I think we do have the best healthcare system.
Okay, so again, this is great. More. I mean, essentially, it's not just what's best, but maybe what's healthcare. More who would like to answer on the true part. Panel, yes, sir. Here comes the, anyway, go ahead and scream, it's all right.
Yeah, I echo his sentiment. I think the key word in that sentence is system. You could clearly make a case that we don't have the best healthcare system and who it serves and how it's delivered and things like that, but I do think that we deliver the most premier care in this country. You look at, international patients who come here to get their care. If you can afford it and you have options, I think you're coming to the U.S. to get your care.
Okay, panel. You may not agree as in true, but if you do, Anita, what you think? True, false?
I absolutely want to support these two gentlemen. And I think the issue is a system for what? We absolutely have the best healthcare system in the world, hands down, for number one. We have the most advanced research preparing the knowledge for the delivery of healthcare. We have the most advanced education for healthcare providers. Is there anybody in this room that thinks that you are not in the best healthcare educational program that's available in the world? You wouldn't be here if you weren't. I believe that we have the more access to the best technology, diagnostic abilities. We have access to, we deliver more, we diagnose and treat more mental illness in this country than anyone else in the world does. We are able to identify those problems and take care of them. So there are many, many areas in which we absolutely have the best care. We may have issues with the distribution of that quality care, but that is not necessarily a problem that we as healthcare providers can solve. Many of those factors have to do with something else, which are the social determinants. But I would say for those things over which we have purview and control, we are absolutely the best in the world.
Ken?
I answered false simply because of both the distribution problem and the cost problem. So when I think of best, I think of value, and value is outcomes compared to how much it costs. And so there are other places in the world that, to me, seem to have a better outcome compared to the cost of it. The United States is much more expensive than most other places. And the other reason is because of the inequities in the system right now. Certainly, if you have the money and the right insurance program and those kind of things, you have access to absolutely the best care that's available anywhere in the world, the best education, the best research, all those kind of things. But not everybody has that access, and so that's why I said false.
Stephen?
I said false, except it's time-bound. So if we went back to 1948, this is dead true on. As we advanced, the world advanced a little more quickly in some substantial areas that we've left behind, and distributional issues among them. It also has to do with the fact that we don't really have a system as we understand it here, and other countries do. The world has gotten better faster than we have in many respects, and so as of today, no.
Okay, so what, Ryan, help me here. This says which of the following is or are indices of health care. Can they really select more than one?
They can select as many as they want. Well, 5. They can select 5.
Okay. Now, let me tell you what, this is not a trick question, but I want you to pay particular attention to the word healthcare, because some of these are indices of healthcare and some of these are indices of medical care. And we're going to talk about the difference. But the question, this is sort of my slide. I get to put the words on it, right? And so please mark which are the indices of health care. And then we're going to talk, once you do that, and I'll keep quiet for a minute, then we're going to talk about the difference between health care and medical care. But let's start, assume you're answering which of these are indices of health care. God, I really like this. This is fun.
We're going to be on TV.
Okay, everybody ready? Here we go. Boom. So what, and it's going to be this way, right? It's not going to, okay, so here's what we got. The big numbers, life expectancy and infant mortality. It seems that those are the two that people have liked the best. But about half would still say heart attack mortality, percent of women screened, and hospital occupancy, about a quarter. So about half of you think that most of these are indices of healthcare. In fact, the two indices of healthcare are infant mortality and life expectancy. The rest are indices of medical care. Now, you'd say, well, what the heck is the difference? Why don't we throw that open to the audience? Once I've said those are the indices, what do you think? Anybody would like to speak to how much, for example, how much of life expectancy might be due to medical care? Would somebody like to speak to what maybe the difference between medical care and health care is? And then we'll ask the panel. Go.
I believe that healthcare is everything that you do prior to getting sick with yourself, taking care of yourself, exercise, eating right, and then medical care is what occurs once you've gotten sick.
Okay, great. More. Others? Yes, sir. Steve.
So I would argue that maybe the screening for breast cancer is in fact health care. And I would use the word sick care as opposed to medical care.
Fair enough. Yeah. Go ahead.
I would just agree with the first speaker and put it in terms of primary, secondary, and tertiary prevention. So I'm thinking primary prevention is going to be more in line with healthcare, whereas your secondary prevention comes in when you start screening for a disease, and that would be more in line with the medical.
Okay, panel. Start over here. Stephen, healthcare, medical care.
So there's a spectrum along which we can consider when medical care is engaged in one's lifespan, and it's concentrated, of course, when we're ill and when we seek it out based on being unable to function. So when we have functional impairments, we seek out some repair and can seek medical care under those circumstances. Health is part of your well-being, and we reinforce well-being in lots of ways because it enhances our functionality as opposed to dealing with impairments to our functionality. And so I see a separation then in the way we consider our prospects for functioning better versus having that functionality break down.
Ken, Anita.
Yeah, I would just build on what everyone else has said. I think there's a component of health promotion and health care, which involves increasing individual and population resistance to things that are unhealthy for them, whether it's an illness or whether it's violence or whether it's accidents or whatever it is that may contribute to a less than desired life expectancy. I think health care has been expanded in some settings to include those things that I think are outside the purview of those of us who are healthcare providers. At least we have that name, that there are many, many social and cultural and genetic and other issues that determine life expectancy or any of these factors on here that are well beyond that which we can do. We can maybe try to inform, but all of those things taken into consideration in terms of that can predict not only whether someone will get ill or become infirm or need medical attention, but also increase our ability to perform, to enjoy life, and to pass on good genes.
Ken.
I think this is really interesting because clearly I think everybody pretty much got that life expectancy, infant mortality are kind of indices of healthcare and in a broader sense than just the amount of medical care that people get. The one and on the other hand, hospital occupancy is clearly around medical care, sick care, that kind of stuff. The one that's sort of interesting to me in this is B, because the percent of 50-year-old women screened for breast cancer is not just about, to me, not just about the medical care that they're getting in a provider providing that care, but the social awareness of the need for this, and that this has some other sort of bigger impact on health than simply treatment of a heart attack or treatment at the hospital. So, I kind of like that there was kind of a split decision on breast cancer screening because I kind of look at that and there's like three different things up there. There's two things that are clearly indices. There's two things that are clearly kind of medical care, and then there's this one other thing up there.
Sick care. Very good.
Yeah.
So,
Tim, I'd like
yeah.
to speak to one thing before we go on.
Go ahead, sure.
Oh, thank you.
No.
You are just evil. I'd like to speak to the issue of infant mortality. I'm not so sure that it's a clear indicator of what we know about the health care because, especially when we're comparing one nation to another and ranking ourselves, because there are so many different ways to measure that. They're not all being measured consistently. The same thing in terms of life expectancy. Sometimes you'll see the studies where they're measuring length of life based only on those things that could have been impacted by medical intervention. And other times it's based on any kind of reason that somebody would die. So unless we're making sure that all of our comparisons are measuring the phenomena in the same way, it's very difficult to determine, number one, how you compare one against the other, and number two, how big of a predictor it really is in terms of intervention through healthcare. One of the biggest factors impacting infant mortality in this country is the large number of teenage pregnancies. We know they don't gain as much weight, and maternal weight gain is a direct predictor of infant weight gain and linked in the health of the pregnancy. So when we start labeling factors as predictors of how well we are providing health care, how good our health care is, I think it's very important that we not necessarily discard it, not say no, but that we be very, very careful on how it's being measured, and then when we're comparing one to another, that they're being measured the same way.
So there is a study, and I want to come back to this in a minute because we're about to have 2 more questions about this. It's actually not a study, it's a paper. And it was published way back 20 years ago in the New England Journal, and everybody continues to refer to it. It came out of the Institute of Medicine, and I think there is plenty of reason to try to develop empiric data around what this paper said. What it said was they were talking about the determinants of life expectancy. And it said 40% of life expectancy is due to our own behavior. Now, our own behavior goes all the way from smoking, drinking, killing each other, accidents, opioids, the stuff we do to ourselves. Now, where'd that number come from? Out of the air, okay? They then said 30% is due to genetics. Well, that's sort of, where did that come from in 1992? Probably everything is due to genetics. But that was the number. Then 20% was due to public health. And that was things that we know about, immunizations, safety, seat belts, those kinds of things. Well, guess what's left? And that's 10% is due to medical care. Now, medical care, what you hear most of us saying is the stuff we do. Okay? Medical care is, as Steve would say, sick care. Now, it's not quite that. That certainly was the case 25 years ago. But the docs of the world and the nurses of the world are now being, I think, appropriately saddled with prevention. Back 25 years ago, everybody would say, oh, healthcare, that's prevention. That's that stuff over there. No. The prevention, the thing that it is now up to us, docs, nurses, other practitioners, to work with patients to have them take better care of themselves. So that's not healthcare necessarily. This is, this is stuff we're supposed to do as well. But the important take-home of this is whether it's 10% or 20%, it is not a big number that physicians and nurses and hospitals do. The big number is what we do to ourselves. And therefore, when we talk about expense, and we will, if you think that we are expensive, and we'll talk about just how expensive, the question of how do we make ourselves less expensive when only 10% is medical care is an interesting question. Okay, now, here we go.
Only one quick comment, though.
Quickly.
Nursing has always been about health promotion. Even Flo said
Even
that.
back to Florence Nightingale. Quickly. We've got about 15 of these, so keep going. Huh?
Can you introduce the panel?
Oh, I'm sorry. My goodness, yes. This is, we will start, actually, why don't I do this? These are really startling. Why don't I let them, seriously, I mean, Anita, Ken, Stephen, introduce yourselves with what you do.
Okay, I'm Anita Hufft. I'm the Dean of the College of Nursing at Texas Women's University and a forensic psychiatric nurse by trade.
And I'm Ken Yonda. I'm the CEO for Community Health Choice. We're a safety net health plan that covers about 400,000 Houstonians with health insurance.
I'm Stephen Linder, a professor at the UT School of Public Health, director of the Institute for Health Policy, and the associate director of the TMC Health Policy Institute.
And I apologize, I'm Tim Garson. I'm the director of the Health Policy Institute for the Medical Center. Thank you for asking. Now, Anita is going to say appropriately that life expectancy may not be measured exactly the same way. Life expectancy is a lot easier to deal with than infant mortality for a number of reasons, which we'll talk about. Life expectancy is a little easier, dead is dead. And so please make you get one vote here. You don't get to vote for more than one. Where does the US rank in the world in life expectancy? 1 is best. Sort of about ready? So that's a pretty sophisticated audience. Okay, I mean, it's actually 53 right now. We bounce back and forth in the 50-50 club with both infant mortality and life expectancy, which is awful, right? But there are plenty of people that would say, are we number one in less sophisticated audiences? And that's a whole lot of fun to talk about that. I think an important question, on the other hand, is why? And I would ask the panel, maybe, and the rest of you, but let's start with the panel, of what is it? Pick maybe 1 or 2, not 50, 1 or 2 things that you would say, this is why we rank as poorly as we do. Stephen.
The data by age cohort are really alarming when you see the rates of violence taking our kids in the 20 to 30 age cohort. And it's dramatic, and it skews the whole distribution of life expectancy. A lot at the higher end in the 50s and 60s has much more to do with obesity and all of the diseases that are tied to metabolic disorders and the imbalances created through obesity. So I'll leave it at that.
Okay.
Oh, well, I certainly agree with Dr. Linder on the problem in the younger ages, which is violence, and a lot of that is, every country above us has a much lower rate of gun violence in the United States. The rest of so that's clearly one part of it, and I won't get into a political speech about that, but that's just one factor. I think the other thing is that it's very clear that the lower income population in the United States does not have as good of as high a life expectancy as rich people. So it's better to be rich and educated and have a good job to improve your life expectancy. And so there's that factor as well, that we have a fair amount of disparity in life expectancy by income as well.
Anita?
I don't want to go last because it's hard. They've already
Okay.
covered all. No, it's okay. We know we have sedentary
can just
lifestyles
say,
in this
yep.
country. We know that, again, there are cultural phenomenon that have grown in this country around the different populations that have immigrated to this country, and which have predisposed us to some very different kinds of eating patterns and access to different kinds of foods. We have industries. We are so impacted by television advertising, and being a free economy, there is no control over whatever's out there hardly. So we have a lot of habits related to what we take into our body, not only foods and other things, which are promoted in our culture. That, combined with the sedentary lifestyle and the prioritizing other things other than our health. Our culture is not noted for being health-oriented. drug-oriented maybe, care-oriented maybe. Give me a pill to make it better, but don't ask me to do something to make it better, so.
One thing I meant to mention, one thing that it's not is smoking, which is interesting to me that there's countries that have higher rates of smoking, but better life expectancy.
They're more
And-
ambulatory.
Yeah.
That seems to,
There are a couple of take-home thoughts, which is that for the last 3 years, life expectancy has decreased. And that was up until 3 years ago. Since the Civil War, life expectancy in the US got better and better and better. And in the last 3 years, it has been obesity, diabetes, and drugs. Now, the thing that just blew me away, and I think when Stephen and I talked about this, and Ryan and I, the number of teenagers killed with firearms in the United States is 83 times the percent in Europe. One more time, teenagers killed with guns, 83 times the percent in the European countries. Moving right along. Okay, infant mortality. Now, we don't need to, because I already gave you the answer, right? We're in about the 50-50 club. Interestingly, these data, you'd sort of say, what? The CIA? Yep. When you go and you look up infant mortality and life expectancy in the world, those are on the CIA websites. Why? I don't know. But it is interesting that's where the data are. Now, we can sort of move past this, but I think Anita's point is important, and that is that there are there are serious differences in reporting. All right, infant mortality has the same definition throughout the world. The World Health Organization says under a year. That's infant mortality. Neonatal mortality is under a month. Okay, the definition is the same, but the reporting of tiny preemies in Africa is not the same as the reporting in the Texas Medical Center. And so there are serious, and there are studies that we've got in our book pointing to the difference in reporting. But one thing seems pretty clear. It does not, we don't get to being in the 50-50 club by reporting. We have really awful infant mortality, and we have really awful maternal mortality, which you would think it's a little bit like hospital readmissions. They ought to be 0. What? Yeah, hospital readmissions in the first 30 days should be 0. What should maternal mortality in the United States be? 0. It's not. So we have, and there are a lot of different reasons. If the panel if you've got a couple of things you'd like to say about infant mortality before we move on, and you can start.
we do have the lowest rate of complications and injuries for vaginal deliveries in the world. Unassisted, unmediated, just, so I thought that was good. I'm looking for the good.
I would also say, since just other fun facts, since we're talking about fun facts, Community Health Choice finances 25,000 deliveries every year, so we know something about infant mortality and maternal mortality and all the rest.
If you could do one thing to fix either infant mortality or maternal mortality, boom, you can do it, what would it be?
Less obese pregnant women.
Mm-hmm.
That's and because obesity then leads to high blood pressure and other challenges, gestational diabetes, those kinds of things that end up with severely premature babies and stuff. And so skinny moms do better.
Tell you
Unless
what,
it's too far underweight, which
Yes,
is what you
yes,
see in our adolescent
yes,
moms, and that's the
yes,
biggest
yes.
contributor to.
I'm
yeah.
a pediatric cardiologist in real life, and I just read today obese women have a higher incidence of congenital heart disease births. What? There's another one. Stephen, thoughts on, or on we go? Okay, here we go. You get to answer the question. The U.S. wastes 5 to 10% of its medical care spending. Now, medical care, docs, hospitals, that's stuff. Not, so between 5 and 10%. 3% would get you false, 12% would get you false. So between 5 and 10% of medical care spending, true or false. This probably isn't let me just make sure. Yeah, oh, okay.
You have to define it.
So why don't we start there? Anita, how would you like to define waste?
Great. Waste to me would be using resources to do something you didn't need to do. And therefore, you would have had the same outcome without it. That might be one way to approach it.
Ken, Stephen?
The trick to me in that definition is that as an insurance guy, I would define it that way, right? But there's also
yeah.
a slightly different, because basically you say we don't want to pay for stuff that doesn't improve outcomes, right? If it improves outcomes, then we'll pay for it.
Yeah.
But of course, then there's a question of how much it improves
Yeah.
outcomes. And then the other part of it is whose definition of
Right.
it improving the outcome. Does it improve your outcome if you feel better about the fact that you had a sprained ankle by the fact that you had an x-ray that said it's not broken, right? The treatment didn't really change. It didn't really improve your outcome that you did an x-ray on your sprained ankle, right? What helped
How
was
many people? What about the
Yeah.
one that it did? You know?
well, so the point is that definition of waste is very, very difficult, but I certainly think that it's, I'm in the camp of thinking that it's more like 25 or 30% than 5 to 10%.
So here's, and it went by quickly when Ken said it. We would all agree that waste is spending on stuff that doesn't help. Okay? That's easy.
Help what?
Okay? Spending money on stuff that doesn't help, that's easy. Spending money on something that helps a little is hard to define. Wasting, that's easy. You do something for the patient, didn't help him. And it wasn't ever going to help him. Got that. But is the $120,000 per month cancer chemotherapy waste or not? And so that is the issue here on the definition of waste is not around, doesn't do any good. It's around how would you define doing a little bit of good or doing enough good, and that's difficult.
And I would also
It's not
say peace of mind.
Yeah.
What is peace of mind worth that you don't have something?
There's another related issue, which is nobody ever wants to touch, so I'll say it anyway. One of the things that drives the cost of healthcare in the country is, of course, the cost of litigation. So we have a lot of, quote unquote, that some people would say wasted tests or wasted screening based on the perception that if I don't do it and something happens, I'm not protected. But we are also the leader in the world in protections for consumers of health care. In no other country do patients and their families have as much recourse as they do in this country for addressing what very rarely, but sometimes is a carriage of mismanagement of health care. And that that has to do with some basic values that we have in this country, and it's hard to measure that too, you know. So benefit to what? Waste for what? Depends on who's paying the bill and where it's coming from.
So, how many of you can do this isn't cheating, how many of you have heard of Tommy Thompson? Most of you not. He would be pleased. Tommy
It just says that
Thompson.
they're younger than us.
Tommy Thompson, governor,
Yeah.
Wisconsin-ish, Secretary of Health and Human Services. Not necessarily known for being an erudite, data-based guy. Just, I mean, so the first time that I heard that Tommy Thompson said that we waste 1/3 of our medical care dollars, 1/3, I said, oh yeah, that's Tommy Thompson. Next. About a year later, comes out in the Journal of the American Medical Association, a paper authored by Donald Berwick. Now, Don Berwick started the Institute for Healthcare Improvement, he's a doc, was for 10 months the administrator for CMS, and he detailed exactly how we waste 1/3 of our medical care dollars. Detailed, dollar by dollar. And it just blew me away. But there it is. Now, you can agree with it, disagree with it, and he had areas that we'll talk some about how we might waste money. But 1/3 is a big number. In round numbers, it's $1 trillion a year. Now, to put that into perspective, if you took any way you'd like to cover all of the uninsured, any way you'd like, 200 million max per year. Okay? We waste $1 trillion.
200 billion.
Sorry, 200 billion. So we waste $1 trillion. Yeah, well, that would be nice.
You are good, Ken.
But if we could save
That's still a lot less than
20%,
$1 trillion.
if we could save 20% of what we waste, okay? Much to my surprise, Ryan and I and a number of people in this room have helped us put this book together that's coming out. And I just think that's such an important article. We've got a whole chapter on that article, and then a chapter on, well, what could we potentially do about it? Much to my surprise, I asked Don Berwick if he would be interested in writing, this was 2011, in writing a 2019 with a couple of us, not just to update the numbers of waste, but to come up with 1 or 2 things per area. He had 6 areas of waste that we could actually do something about in the next 3 years. And he's agreed to do that. So we'll see how that works. But I would say that, and I don't think the panel would disagree a lot, but feel free, we cannot figure out how to cover, pick a number, 25, 45 million people with health insurance if we don't reduce the price of health care. Just can't do it. And Ken has this first base, second base, third base, fourth, home plate analogy, but feel free. But, right, I mean, we're not going to get there if we don't cut, we just can't get there with healthcare costing what it costs now.
And I would,
Sure.
When you say waste, does that include a judgment on profit for does waste include a judgment on the profit of doctors, the profit of insurance companies, the profit of medicine companies?
It does. I will make sure that we have, that Ryan puts up on our website the reference to that article. You can imagine, Mr. Hall, that gets touchy to write about, you can imagine. So does because then, are you anti-competitive if you say that the drug companies are all in the Fortune 50? Do they need to be? Not by my stretch of the imagination. They don't need to be. But are you a bad person if you say that, profit is bad? Relating to what you're saying and relating to what Anita is saying, and then we're going to ask each of you, I'm not quite sure how we do this, what's the biggest thing we waste money on? I'm going to ask you in a minute. But I want to posit to you a problem. And that is, and there's data on this. So you ask a bunch of doctors, well, and there are studies on the number of tests you would do. There are these studies that there's one on obstetricians and cardiologists and general surgeons, and they give them a bunch of patients and they say, okay, would you do this test? Yes, no. Why? Oh, well, malpractice. And then you go back, because that study comes out, but it was in sort of a focus group. And they didn't get the opportunity to say, to make money. Then gets published in JAMA, Journal of the American Medical Association, last year, that when you ask doctors about other doctors doing things to make money, 71% say those people, those doctors, those people, those awful people do things to patients to make money. Not me. The problem with sort of unwinding motivation is there's no way. I was part of a group 15 years ago in Washington that we closed something called the Office of Technology Assessment. And the last thing we did was they said, okay, can you look at a chart? Can you look at a patient's medical record and tell if the doctor was practicing defensive medicine? Can you look at the chart and say, okay, this obviously, example, patient rolls into the ER, has a head injury, hits their head, and you get a CT of the brain. Was that because of malpractice? The panel decided you could not tell without asking the doctor. The doctor, to put it nicely, does not always say what is exactly on their mind. And so it is difficult to answer Mr. Hall's question of how much of medical care is due to physicians either doing things because they would make money, or because they're worried about malpractice, or because they're worried about taking care of the patient,
That's right.
or because they're curious, or because they're worried. And when I've read pantloads of these studies, and what winds up happening is they all say everything. So it's not helpful.
Just another quick way that I think about the answer to your question too is that if you compare the United States to other countries, far and away the biggest difference in cost in the United States is that we pay the highest prices for drugs and physicians and hospitalizations, those kind of stuff, more so than utilization of more services. Now, there are certain things, mostly diagnostic testing, the United States does a whole lot more than other countries. But if you look at waste, both in terms of high prices as well as from an overutilization standpoint, it is more on the price side. Now, the question is that waste or not? Other countries educate physicians differently so that they, in terms of who pays for that, so you don't have to have as high a salary as a physician in other countries. And there's lots of differences, but I think we waste money on all the administrative expenses in the United States too, as well as the actual care itself.
The number that Berwick has, and I'm going to give each of you an opportunity to free text this in a minute of what you think is the biggest way that we waste money. Berwick's number is $200 billion, $200 billion a year in overtreatment by physicians. $200 billion a year. More on administrative waste. You know, electronic records that don't talk to each other and all that. So I wish I could answer it in a more erudite way, except to say that there is one, I think, important study that gets not enough credit, and it comes out of the School of Public Health. 10 years ago, maybe, Atul Gawande, is that a name that some of you know? Okay, Atul Gawande, Harvard neurosurgeon, health services guru, writes a paper in the New Yorker, writes an article. And the article says that McAllen, Texas, has the second highest rate of expense per person in Medicare in the country. One more time for the fans. McAllen, Texas, second highest in the country in per capita spending on Medicare. And he writes a long 16-page article, that was the point. So the folks at the School of Public Health went and looked at Blue Cross and said, well, if Medicare has the highest in the country, I wonder what if we did that same analysis for Blue Cross Blue Shield, whether patients who have medical directors that determine whether or not a test is done, Blue Cross, rather than Medicare, who has no governance at all on tests being ordered. Well, it turns out that Blue Cross Blue Shield, McAllen, Texas, is right on the median. And so the implication in that article is that the physicians of McAllen, Texas are perfectly cognizant of what they're doing, and they are charging Medicare a lot where they are not charging Blue Cross because they can't get away with it. Now, that's not my conclusion, that's the conclusion of that article, but those two articles juxtaposed get, again, a little bit about there's a problem here. This is not surprising to the medical community. CMS, the Center for Medicare and Medicaid Services, has determined that fee-for-service, which is what we're talking about, where doctors get to order anything they want at any time, has got to go away. And so this is not our impression, this isn't what, you know, we're not, this is just fact that when permitted to order a bunch of tests and order a bunch of operations, it just is human nature that goes up. Yes, sir.
Yeah, I think that the most interesting piece of all of what's going on in McAllen is that the major hospital system of the Rio Grande Valley is called Doctors Hospital Renaissance. It's a physician-owned system. So you talk about misaligning incentives.
Correct.
If you couple that with fee-for-service compensation,
Correct.
if they were paid per capita, maybe they would.
Correct. Okay, now, Ryan, how does this work? How do people get to do this?
So just, you're gonna type your answers, and we're gonna see what comes up. If you use a swear word, it's gonna get blocked, so don't say those damn doctors, and we'll see what happens.
And so, but these are going to come up live as people
There you
type
go.
them. There you go. Okay. This is terrific. I love this. Start typing. This is great. And I guess you can type in more than one, or you get to type in just one?
Type in more than one.
Okay. God, I love this.
It might get
This is so much fun.
very small the more we get. We'll see what happens.
Did I submit mine? I don't know.
There is a footnote to all of this from the economist's perspective. Not that I'm an economist, but from an economist's
But you have a
perspective,
perspective.
I have the perspective. And that is in a consumer a demand-driven economy, which is responsible for our economic growth. Your waste is my payroll.
Yeah.
And
actually
so
contributes to the
we're generating
GDP.
economic
Yeah.
growth through the healthcare sector here in the region, and you could identify what you would consider to be waste in the sense that you would like to reallocate that spending for something else. But when you reallocate it for something else, you're taking it away from the person who's getting it now. And so what you've got is this problem of redistribution connected with the assignment of waste when you identify who the people who are getting paid with what you consider to be the wasteful expenditures, and that they need to give up that income so that it can go for another purpose, so that other people can get that income instead of them getting that income. So be cautious around your expectations around what constitutes waste and what's someone's lunch.
Modified somewhat by lobbyists. Yes, sir.
I'd like to bring up something else. PCI, percutaneous interventions, are one of the procedures on the list of those that are overutilized for some time now. And there's a recent paper about it.
This is stents, guys.
More or less
That's a nice
confirming-
way of saying
more or
this is
less
putting stents
confirming-
in.
Yeah, but if you look back at the history, this is a fascinating history of PCI, first at one site, then in 2 vessels, and then in 3 vessels, and then in diabetics with 3 to 4 vessels. And at the moment, over the same period of time, as PCI became more popular, and that's a separate subject, the indications became more liberal, so that, say, in 2011, American Heart came out with guidelines that said that PCIs for more than single vessels were a no-no. But when the PCI people grew into such great numbers that they reached should I say, a threshold, and the indications in progressive iterations of the guidelines were liberalized, so that now it's actually possible to do 3 vessel stenting for diabetics with 3 vessel disease, and nobody says a thing about it. But yet the guidelines still say that in diabetics with over 2 vessel disease, one should do cabbage because the survival curves are much less.
So
the
the
second
point being,
the point being that there's more than meets the eye to this about profiteering. It interacts with the guidelines, and it also interacts with what people are doing in advertising of the procedure.
so
what I'm saying,
if
is that
I hear you right,
PCI
because we got to move on, if I hear you right,
But
the
the-
docs are changing the guidelines in their own
That's
favor.
more or less it.
There you
Now,
go.
in Europe, in contrast, in Europe, when everybody is salaried, they do even more PCIs. And I suspect that the reason for that is that each institution or physician is after status rather than an increase in income. But there, the liaison with private industry is much more tolerated than in the United States.
That would be sure. Thank you. Okay, panel, I want you each to pick one. Okay, I want you each to pick one of these and speak a little bit about not just is it, because of course it is, but the question is, what might we do about it? So pick one. I'm going to save prevention. So,
Can I say something?
yeah.
So you guys had so many responses that I can see more on my phone than's on my screen. So if I can just add a few that
Sure.
you can't see on the
Yeah.
screen.
Is this a swear word or not?
No, that's
Oh,
just,
okay.
this is drugs with 7 S's for some reason. What I didn't realize
But a lot of
is,
people like that.
I didn't realize that y'all would be able to vote for them, which is kind of interesting. So beyond what you can see on the board right there, a lot of patients demanding something to treat their problem, lack of communication between sectors of the medical industry, a lot of talk about EHRs, high physician wages, fee for service, regulations, and the one that was downvoted the most, interestingly, was entrepreneurial doctors.
When you say downvoted, you mean?
You can vote up or you can vote down on the responses, and people voted down on that one, which I thought was interesting.
I'm sorry.
What does that mean?
Meaning,
People disagreed with that one.
Oh, okay, okay, good.
Oh, I wasn't that.
that's interesting.
Innovation's a good thing.
Woo, isn't that interesting? Okay, so panel, pick one, and how do we fix it?
Okay, let me do administrative costs.
Okay.
And that was probably pretty straightforward. So we've got a substantially fragmented system with multiple payers and accountability demands that vary depending on the point of service and the providers involved and the guidelines. You've got the sense of the complexity of the system involved. All of that grinds through an administrative process of increasing complexity. So it's very expensive to have a fragmented system where everyone has a little piece. The alternative to a fragmented system is a unified system, perhaps going to a single payer kind of organization that happens to minimize the administrative costs connected with the expenditures for medical care. And so that's an argument for a systemic reform to minimize those administrative costs as a total system by changing the nature of payment within the system.
And so if you got to fix administrative, what would you do to fix administrative waste?
You're going to like this.
I'm going to love it.
Medicare for all.
Okay.
See, you
getting
did
there.
like it.
We're coming to that. So
Yeah.
hold your thoughts here. We're coming. Ken.
Well, I should talk about drugs but it's two different issues with drugs, because drugs, both the number of drugs that people take and the number of people that take 5, 10, 15 prescriptions every day, that I question the value of that in terms of improving their quality of life. But there's also the highest costs. You know, the United States pays more for drugs than anywhere else. So, yeah, the trick with drugs, actually, the fix to the drugs is to get Congress, both at a state as well as a national level, out of the business of protecting the pharmaceutical manufacturers. But you know, that's amazing amount of lobbying goes on to make it almost impossible for either the U.S. government to control prices of drugs, or at the state level, or for there to be much negotiation. And with all the rebates and everything else that goes on, it is the sleaziest part of the healthcare system by far is drugs.
There's a lot of candidates.
But
that's
mean,
not what you
clearly,
wanted to talk about.
But
Go
what I
ahead.
want to talk about, though, is actually the one that I wrote down that doesn't seem to be that popular, which is the moral hazard created by the insurance industry. So even if you had Medicare for all, which I'm not sure is the right answer, but that's for a few minutes from now, the reality is if you combine a fee-for-service payment of physicians with the fact that pretty much everybody has insurance, I mean, forget the uninsured for right now, but you know, 90% of the country has insurance, where it's like, don't worry about it, somebody else is paying for it, it's highly subsidized by somebody else, that creates an environment for waste and overuse. It's like, of course you're going to get all that diagnostic testing. Of course you're going to get the surgery. Of course you're going to get the drugs, because it's all covered by your insurance company. And so I actually think those of us who spent their entire adult life in the insurance industry own a whole big piece of this, not just on the administrative expense side, which we could do a lot better on administrative expenses even without Medicare for all, and we should be doing a lot better on administrative expenses. But I just, that whole economic concept of moral hazard, I think is a big issue that we have to deal with. And that doesn't mean that high deductible health plans with a health savings account actually work. So just for those of you who think that that's the answer, there's no evidence that actually works.
A frightening number that I've got to, I've read it a number of times. High deductible health plans, okay, so $6,000 deductible-ish. 6% of people, check cost or quality in a year. 6% who have high deductible health plans look at cost or quality data. What? And so it is much more, it's amazing how little that we, the consumers, actually pay attention to this stuff. I about fainted. You almost lost me about a year ago when on this very podium we had a quality session, and I wanted to know, because I knew these data, and I wanted to ask the panel, what do we do about that? What do we do about the fact that people don't want to look at cost data and don't want to look at quality data? And one of the very erudite, good panelists said, oh, those data aren't for patients. Not sure I'd agree with that one. Anita.
You didn't give me a chance. My solution is not to get rid of insurance.
Of course not.
Because we all actually need insurance. But what we have to do is change the compensation system for doctors and hospitals and stuff. And we've got to move away from the fee-for-service. The more you do, the more you make, kind of.
Or you nationalize the insurance industry.
There is, by the way...
You could do that, and you could do Medicare for all, in which case the administration...
Okay, we're going to get to that. Anita,
You're just redistributing
Anita,
who pays for
Anita,
it.
pick
I am
one.
really struggling with this because I'm not sure those are all actually wasteful issues.
Well, no, go ahead and pick one you like.
I think the only one that I could not argue against would be the issue of patients demanding the right to make decisions over what their care should be when it's being based on misinformation, requesting antibiotics for a condition that's not going to respond to it. I think that this is one area where actually education may work. We know it doesn't work most areas. Education does not change health behavior most of the time. We all know that. It's a necessary component, but it doesn't work. But I'm thinking if there was a disincentive for demanding a treatment that had no evidence, i.e. not only was your insurance or your provider not going to pay for it, but if there was evidence to show it was actually not to your detriment, that you had a penalty put on top of that, I think that may decrease some of the behavior.
We had a physics professor that if you answered on a multiple choice test, if you answered a really dumb answer, you got 2 off. All right, I am absolutely certain there is passion in the audience. Let's take 3 people who really want to say something about one of these things. 3 hands. If you want to say something, here's your shot. Yes, ma'am.
We have providers who can provide care, excellent care, at less expense than other providers, i.e. we have nurse practitioners who are not allowed to practice to the full scope of their license. And in other states, they can, but not here.
Others really feel strongly about something, here's your shot. Go ahead, to your right, thank you.
I was interested to see the end-of-life care one, and one of the things that I'm always concerned about is how people end up in hospice care with less than 2 weeks left of life. And why is this not being addressed much sooner? That would increase the quality of life and also the cost effectiveness. And I think there's also issues within hospice. A hospice is not a hospice is not a hospice. And what I've observed is sometimes oxygen and the drug packs go in way before they're absolutely needed to be there. And I'm wondering, is that so that it can be charged on a daily basis? Just some issues, and that's not really my field.
We do make the suggestion, because this is tough, as you well know. If it was easy, we'd fix it. But it's really tough, and it is not, by the way, the amount we spend per, in terms of the percent, still around 10, 12%. Same thing in the Netherlands. So the percent is not as different as people might think. It is tough to do. We make a proposal that if somebody is really, really sick, whether you're really going to die in the next 6 months is less of an issue. If you're really sick, you probably ought to be in palliative care 2 years earlier. Never, you know, and then figure out how that palliative care helps to manage that patient. But 2 years earlier. The problem with, living wills, it's great. You save 7.5 minutes. So anyway, let's go on. Okay, this one's pretty straightforward. Preventive care saves money, true or false? Five, 4, 3, 2, 1. Okay, would anybody in the audience that answered false like to speak to why I agree with you? So go ahead.
Hey, so I admit that I was here last year, and it was a very memorable.
I could have gone all year without that, but go ahead.
Yeah, and so I remember the answer to this one because it's a very memorable reason, and the answer was because preventive care makes people live longer, so they cost more.
And so, in fact. This is, so thank you for remembering, I guess. This is a study, and then we can. This is much more complicated than this, but this is a study well done from the Congressional Budget Office in the New England Journal of Medicine, where they looked at every possible expense. They looked at, were you working? Were you not working? Were you spending medical care dollars? Were you spending non-medical? Well done. And the answer, the premise was, if you increased the cigarette tax today by 50 cents a pack, what would that do to the federal budget 30 years later? And the answer is that people live longer, and therefore they spend more money. They will cut down on smoking, and they will live longer. Now, the real, I think, every time I talk about this, the thing we've got to make sure to say 56 times is the purpose of preventive care is not to save money. That's right. The purpose of preventive care is to live long and happy lives. And so it is not about, the idea is not to try to save money with preventive care. It's very complicated because the time frame matters, right? There are clearly, workforce prevention, fall prevention programs that work very well to save money. In the next week, flu shots save money because of people not missing work. So it's very complicated. So it has to do with the time frame. You wouldn't always say preventive care doesn't save money. But the important point of this was in the presidential election in the first Obama-Clinton-Edwards time, in February of 2008. Each of the three of them had on their website, we will take the money from preventive care and fund the uninsured with the savings from preventive care. And there was an article in the New England Journal the next day, starting out in the title that said, presidential candidates, stop doing that. And so the point is not that preventive care is bad. Preventive care is great, but the money for the uninsured is not there. That's the point of this. Thoughts, panel?
So preventive care saves you money, okay? It saves you money. Systemically, it's a loss. Just like trying to get people to stop smoking because they live longer and draw down Social Security Trust Fund and eat up all these other funds when they were around. But hey, we want people around so the benefits exceed the costs.
Really, there's a,
But that argument, the whole thing is specious in the sense that then why would you have healthcare at all? It would save all of us all kinds of money.
Well, it's not to save money.
it's not specious.
It's not a money, it's not a money make, yeah.
The appropriate.
Okay, Steve?
Well, I would point out that curative care doesn't save money either. And I think that it's important to think about the cost effectiveness of different interventions. So while it's true that many preventive interventions do cost, but when you look at costs per quality adjusted life saved, they are substantially less expensive than most curative interventions.
Yeah,
So
I mean,
I
it's
think we have to think about
really
that as well.
interesting. There are a couple of really interesting articles that put them right side by side. Yeah.
I just have to say on behalf of the entire insurance industry, even though I shouldn't ever talk about the people I used to work for, the for-profit guys that are in it for money, is that we all focus a whole lot of time and energy on making sure that all of the members of our health plan have preventive care. No matter who you're insured by, you've probably gotten calls. Make sure you get your flu shot. Make sure you get preventive care. And you think that that's because insurance companies are trying to save money. But it really does matter if it's a short-term thing like your flu shot versus something that saves the insurance company later on when you're actually on Medicare and not on our plan anymore. So some interesting, weird dynamics in the insurance industry. But generally, we are in the business of helping people stay healthy, even if it costs us more money. And it's still a good thing because people like to have preventive care and we like to actually keep people happy.
It's absolutely the right thing to do. And as Anita tells us, that's what nurses do.
We hope so. When I was in Georgia, we had a nurse-managed clinic that was run for the underinsured, the people who didn't qualify for Medicaid or any other free care. We operated a free clinic and had a grant for that in collaboration with South Georgia Medical Center, with the idea that we would save them money because we'd have less emergency room visits for people for non-emergent care. That's your big goal, right? In the first year, because all these folks that we enrolled started coming for regular visits to get their undiagnosed diabetes and heart disease and high blood pressure and everything else treated, our costs exceeded the previous 2 years of emergency room visits because now they were getting drugs, they were getting treated, they were being seen for other things, we were diagnosing more. It took us 5 years to start seeing, and it takes a long time to change behavior.
Every bit, this is fun, because again, Ken wants us to keep going. Because
Well, I guess I got another
12
one that I
minutes.
like better.
We
We
got
got
12
12
minutes to
minutes
go. So let's move on. All right. We're going to zip through some of these. This is yes, no. We're going to say a little bit yes. We're going to not say quite so much about some of this. True or false? Everybody, underline, everybody with income less than $15,000 a year are covered by Medicaid. Thank you.
Smart group.
Those of you that answered true, wrong. Okay. Medicare is free for all people over age 65. True or false?
We have a hardcore group here.
20% copay, right? Or 20% coinsurance. So it ain't free.
Can I say one thing about
Sure.
this? I am continue to be surprised by how many people that I talk to about Medicare say, well, Medicare is better than Medicaid because I paid my tax for Medicare my entire working career, right? Part of your deduction from your paycheck is and your employer makes a contribution. And many people don't realize that that only covers Part A, which is the inpatient hospital piece of it. Part B of your Medicare, in addition to you paying, you have a deduction from your Social Security check each month for your portion of the Part B premium, but that Part B premium that you're paying only covers maybe 20% of the cost, and then you have co-insurance on top of that. But the rest of that is actually coming from general revenue funds, the same way that Medicaid comes from general revenue fund.
Yeah.
And the same way for your Medicare Part D prescription, the amount that you're paying for your Medicare Part D does not cover the entire amount. You're paying just a part of it, much like when you have employer-sponsored insurance, your employer is paying most of the cost and you're only paying a portion of it. So it's really surprising to me when we talk about Medicaid versus Medicare and stuff in terms of the financing of it, how many people kind of don't see Medicare as an entitlement, sort of like they see Medicaid, but it's like, you know, the actual amount of cost to the government outside of just the payroll taxes in Part A is actually pretty high.
Okay, we've got 10 minutes, so we're going to zip through this. All right. So the Medicare statute says that the U.S. government is not permitted to consider cost in what it covers. The answer to this is true. The United States government is not permitted to consider cost by statute.
There are some things that they disallow, though.
Not
I
by
just had mine.
expense.
Oh, not by expense.
Not
But
by
that's not what that
expense.
question said.
Okay. All physicians must agree to see Medicare patients? Nope. Okay, there is no managed care in Medicare. It's sort of a double negative. There is no managed care in Medicare.
Are we supposed to be voting, or are you just telling us?
Oh, yeah,
the
go ahead,
answers?
sure,
No,
yeah,
no.
please. No managed care in Medicare.
Oh,
Wait.
interesting.
Okay, Medicare Advantage is a managed care plan and is available. So therefore, the answer to that is there is managed care in Medicare.
Yeah. And growing very fast.
Yep.
Over 30% of the population.
That's the best
Now,
question so far.
This audience, I suspect, okay, I think we might get a little different answer from others than this audience, but some of the things we've been talking about, do you find yourself saying, oh yeah, I knew all that? Okay.
You
Even in
get
this
so
group.
honest people.
Yeah.
I still resent the fact you have to.
So
And take.
I'll keep
that little
going.
card. I don't think you should have to do that. Especially if you're still
Okay.
working.
Medicare for all means I get free health care and don't have to pay.
I thought there was going to be an answer of I don't know to some of these.
I don't care.
Well, no, I just.
Medicare, okay.
I don't know what Medicare for all means in
That's
at
coming.
any level.
That's
so I don't know if
See,
I
he
should
does
answer
this
true or
to, he
false.
does this to.
That's
stimulate
coming. Under Medicare for all, I
conversation.
may have to pay more taxes?
I don't know. Oh, yes, definitely
Yes.
true on that one.
Absolutely. That's a given.
The odds are pretty good, yes.
Except
Under
that
Medicare for all, more
nevertheless, they
expensive
have-
drugs, tests, and procedures will be covered as they are now. Medicare for all, you get the same thing.
Who knows? Nobody knows. We don't know.
I cannot imagine. That's one of the issues with Medicare for all, is they don't, you know, they can decide what they want to cover under Medicare for all, and it sure is not likely to be what it is now. Okay, under Medicare for all, no private insurance companies would be available for anyone. And let's
Successful.
call this under the bill as proposed by Bernie Sanders,
Oh, I have no idea.
okay, which is actually the only bill on Medicare for all that's out there. happen. So this is a little bit of a double negative, right? Under Medicare for All, no private insurance companies would be available. The answer to this, ladies and gentlemen, is true. The answer to this, ladies and gentlemen, is true.
Under that one proposal.
Bernie Sanders,
Under his
and I'm only saying it's that plan, I'm identifying it by the person, has proposed a Canadian, Medicare for All Canadian system where there are no insurance companies. Canada is the only country in the world that basically has a true single payer with no private insurance. England, France, Germany, Japan, you can buy private insurance. Very, very limited in Canada, and in the Sanders bill, not at all.
But
Medicare.
Insurance companies are like roaches. We'll figure out a way to survive.
Oh no,
anyway.
that's. You saw my.
No matter what.
You saw
No
my.
matter what.
You
It's like
saw
we'll
my
sell insurance to
op-ed.
the undocumented people
We
who are
need
not
a single
eligible for
safety
Medicare.
net. Medicare for All means a single safety net where everybody
Hey,
gets
whatever
health care, but they also buy private insurance. That's the flip side of this. That's the flip side of this. In the current proposal, it is not for a single safety net. It is for no insurance companies, and I cannot imagine personally that that will ever happen because the insurance companies not only won't, they shouldn't. We should have, I believe, private insurance available. Okay, here we go. So here's the, I really
Here's
don't
finally the one.
understand.
Yeah, 100%.
Okay,
Obviously,
here we go.
Obviously, nobody.
Here we go. Okay.
Yeah, but
Oh, wait, I hit the wrong
that
button.
13% is because you already explained it to him.
Now,
Tam.
huh?
That's because you already explained it to him.
So I think this is the last one, right?
You have to address that.
All right, so we've got 4 minutes. Yeah, we got a few more, but let's end on this. Are people in the audience who, and there's no right answer to this, are there people who are saying false that you'd like to take a minute and say what in your mind a better solution is? There's no right answer to this, but I'm going to end, I'm going to ask the panel the same thing. Or, yes, it is. Yes, or with somebody just putting on a vest. Okay. Yeah, in the middle there.
So I'm actually I came to the US a year ago, so I'm from Canada. So I can tell that the Medicare for All is not necessarily the best system. And I think I don't know what's the best solution. You're asking the best solution, I'm not sure. But definitely like a semi-private or both, a combination of both in some way, but Medicare for All, I have a hard time believing it's the best, based on my experience.
So is there, let me, in the 3 minutes that remain, panel, yes, no, Medicare for All, and if not detail, but what should we be doing and not Medicare for All if it's not?
2 words, the Dutch.
Well,
It's the system in the Netherlands has a nice combination of a provider system that's well organized with salaried physicians, and yet a market that's highly regulated but provides room for insurance companies to function and to cover extra kinds of care as people need it and demand it.
So is it only extra?
It's a mixed system,
it's a
all right?
mix, yeah.
'Cause-
And
but
it's mandated.
One of the
Everybody
best
has to pay
functioning
into it.
mixed systems.
Okay.
Yeah.
Anita, you don't have to be
well,
last. You go
okay.
second and then Ken goes last.
Oh, yay, I don't have to go last this time. Yeah, I think that approach that the Netherlands has would be one that I think we do need a system that still provides incentives for people to go into medicine and healthcare. There's got to be room for profit to develop the best drugs in the world, the new ones and the new knowledge and all of this. So I think we have to have some entrepreneurial room. I like the idea that in the Netherlands it's a mandate. Everybody must purchase health care, and everyone has a $500 or the equivalent deductible. There's an equitable distribution of some kind of burden on the consumer. But we also have to recognize they limit the kinds of things that you can have. I think we've got to be ready for the idea that we will be rationing health care. And that's something we've not coped with in this country very well.
Ken, final word.
I'll have to end with the 4 bases. It's only a month away from spring training. You know, the challenge, I understand why people think Medicare for all makes sense. And when you ask people, they want different things. Some people say it's universal access, and we should have, everybody universally should have access to care and to an insurance system. But Medicare for all doesn't do a very good job of building personal accountability, frankly, and I think personal accountability for healthcare is very important. That's actually first base. Universal coverage is second base. Lower administrative expenses and fixing administrative challenges is second base to third base in my view, and I understand that people think that Medicare for all would do that. I will tell you the Medicare system is damn complicated, and so a better Medicare for all and not having 6 different versions depending on commercial versus Medicaid and all the rest. But also Medicare for all, at least it's been explained to me, doesn't get you from third base to home, which is actually the most important, which is we have to change the way that we pay providers for care, and that's salaried physicians, that's more at risk. That's what, and Medicare for all, if it's still a fee-for-service system, ain't gonna be the answer.
On that note, I have enjoyed this. I hope you have. This has been a blast. Thank you all. Thank you, panel. See you next week. This week, you get food and drink. So out there, plenty of food and drink. Thanks.